everyone. This is Professor DePaulo. Welcome you back to Psych 260, Abnormal Psychology, now online. So in Chapter 6, I'm going to be talking about stress response, post-traumatic stress disorder, and then some of the dissociative disorders. So I'm going to start by introducing the idea of what stress is and what kind of bodily response do you get out of stress. So stress begins with the stressor, which is an event that creates demands. So something happens in our life, like some kind of catastrophe or other personal tragedy, and all of a sudden there's a demand for change. There's a demand for some behavior to address that event. That is the stressor. And the stress response is how you deal with that demand. So this depends on how you judge the event and also your belief in your capacity to effectively react to the event. So do you feel like you're able to cope with the stressor, with that event that's kind of influencing a change in your life? That determines how severe the stress response is. If you feel like you're able to effectively cope, then you're going to be able to deal with that stressor and move on and not suffer any of the long-term consequences of that stressor. If you feel like you're not able to cope with that stressor, that demand, then your stress levels are going to increase and you're going to be chronically plagued by stress, which is going to have an effect on your body and also on your thinking as well. So when we view a stressor as threatening, the natural reaction is arousal and fear. And obviously we feel that way right now. So basically everybody views what's happening in the world as stressful, what's happening in New York City as stressful. And now, can we cope with it? I think one of the problems that we're currently facing is we're not sure how to adequately cope with the stressors in our environment, right? When you're dealing with a virus that's invisible, how do you adapt to it? How do you know what precautions to take? I mean, wash your hands, stay indoors is good advice. I mean, that's a good way to cope with it. But on the other hand, you can't see it. You don't know it's there. You don't know if it's around. And you're not sure you're going to be able to cope with it if you do get it in the unfortunate circumstance. Even though you read the statistics that say, most people, the vast majority of people are going to be fine, except for the older people and obviously people with comorbid health problems, especially if you have multiple health problems, diminished immune system, etc. It could be more dangerous. But we just don't know. We've never experienced something like this before. And so as a result, we don't know if we can cope with it. And that's what's creating this arousal and fear and the sense of panic that a lot of us are feeling right now is we're not sure. It's kind of like taking that test that you're not prepared for. When you sit down and take that test that you're not prepared for, you're going to feel anxious because you deem yourself not able to cope with the demand that's in front of you. Well, that's kind of how we all feel right now. There's no way to fully prepare for what we are about to, take on. And as we watch the numbers grow, we watch people die. It's brings up the idea that we can't cope, or maybe we can, but we're not sure, and that's going to lead to chronic stress, arousal, and fear, which in turn is the opposite of what we want because it's going to affect our immune system. So stress reactions and the fear that accompany them play a vital role in psychological disorders. So you're going to see a huge spike, not just in terms of hospital admissions and people being sick, but you're going to see a huge spike in mental health problems coming forward with this virus. That we don't know what to do with it. We don't know if it's coming, going to be gone. There's going to be a treatment, and as a result, people are going to have increases in, as I said last time, obsessive compulsive disorder, generalized anxiety disorder. All these related anxiety issues are going to be due to this inability to cope and eventually depression. So there is a lot of online therapy resources we should all be using to get an appointment with someone and get treated, if it has to be on the phone or through Skype or whatever. because this is really a difficult time that produces an enormous stress response that it's going to be very hard to deal with. Now, if there's an intense stressor that overwhelms your ability to cope completely, this can lead to what's called acute stress disorder. So this is generally a result of some intense trauma that you have, whether it be a death in the family or severe illness in the family or in your own personal life, or it could be a result of war, being in a war zone, being in the military, not knowing what's going to happen. And certainly it could be a result of what's happening currently in our environment, this virus that can lead to all kinds of, intense situations. If someone, gets sick, that that can be very disturbing, and that could lead to an acute stress response. And over time, that acute stress response can then turn into post-traumatic stress disorder. Now, that doesn't mean everybody is going to develop this. Certain people are more prone to develop acute stress disorder and then turning that into post-traumatic stress disorder. Not everyone is going to develop these disorders. Some people are going to be able to cope better. Other people are not going to cope, but they're not going to develop stress disorders. They're going to develop physical symptoms, or they're going to develop severe depression or another anxiety disorder. So it's really not sort of a one sort of stressor leads to this, or one intense stressor leads to this. Everybody's different. But for those that do develop post-traumatic stress disorder from an acute stressor, this is a very difficult disorder to treat. It can last months, if not years, of the person's life, and it brings a lot of hardship with it. Many people report the inability to work, inability to care for their families, hold a job, go to school, function in a normal environment due to their post-traumatic stress disorder. So the DSM-5 lists these as trauma and stressor-related disorders. There's also other physical disorders related to stress, and these are called psychophysiological disorders, and these are listed under the DSM-5 under psychological factors affecting medical conditions. And we'll talk about the hypertension and all those related disorders due to stress, asthma, etc. So how does the fight or flight response work? Well, you should know that arousal and fear are set in motion by the hypothalamus. The hypothalamus controls the pituitary gland, which then controls both the sympathetic and the parasympathetic nervous systems, which are the subdivisions of the autonomic nervous system. So basically, it all starts with the hypothalamus. It regulates the pituitary gland, and that kicks into effect the adrenal gland and other glands that are in the endocrine system that lead to the fight or flight response. And that's done through hormone releasing. So the endocrine system secretes hormones, which are a little different than neurotransmitters because they exert a sort of a broad range influence in the bloodstream. So they don't have to bind to specific targets. They can just be secreted, and they take on a localized activity through the bloodstream. And they get circulated through the bloodstream, and that's how they have that effect on the body. The autonomic nervous system is divided into sympathetic and parasympathetic divisions. Sympathetic speeds things up, so that is the fight or flight. The parasympathetic system division of the autonomic nervous system slows things down. And that autonomic nervous system is, part of the peripheral nervous system, which is separate, which brings basically the nerves to the periphery of the body, and that is differentiated from the central nervous system, which is the brain and the spinal cord. So as I mentioned, there's two routes for the autonomic nervous system: the fight and flight, which is the sympathetic. So sympathetic speeds things up, parasympathetic slows things down. So that sympathetic nervous system pathway is activated during stress and arousal. And you also have the HPA axis, the hypothalamic pituitary adrenal pathway, which means the hypothalamus signals the pituitary gland, which then stimulates the adrenal cortex, which is right above the kidney, on top of the kidney, to release corticosteroids, which are stress hormones, and they help us cope. They help us regulate blood sugar. So these hormones are constantly being secreted. There's some evidence that if you keep secreting these steroids, right, in your blood, that eventually that will lead to depression and anxiety down the road. So basically this unmitigated pathway, the pathway that's kind of out of control, can lead to anxiety and depression in the long run. Here you have the autonomic nervous system. As you can see, the sympathetic nervous system inhibits salivation, so it creates a dry mouth. It dilates your pupil so that you can take in more light, especially in the dark. It relaxes your bronchi, so it relaxes basically the breathing mechanism. It accelerates the heart rate. It inhibits digestion, which is important, because if you're under a very stressful experience and you just ate a heavy meal, it's just going to sit there in your stomach it's not going to digest. It's going to sit there like a load, and you're going to feel quite ill. The sympathetic nervous system, I should say, also stimulates the release of glucose, and that's basically the glycogen in the pancreas is converted to glucose, which is the body's fuel to allow you to provide energy to the muscles so you can escape or take action. The adrenal gland on top of the kidney secretes both epinephrine and norepinephrine, which are excitatory neurotransmitters. The bladder is relaxed, and this stimulates ejaculation in males. And the parasympathetic nervous system slows things down, contracts the pupil, slows the heart rate, allows you to digest by increasing digestion, stimulates the gallbladder to store glycogen, which is kind of reservoir of fuel, allows blood to flow to the sex organs, contracts the bladder. And that's how they kind of work opposite of each other. You don't want one system, especially the sympathetic, to kind of take over and constantly be going, because eventually your body is just going to run out of energy. You're going to be so fatigued from the chronic stress fight or flight response. So you need that sympathetic nervous system to balance out that excitatory response. Here's the endocrine system for the HPA axis. You have the hypothalamus, which also controls appetite, controls sexual activity. That influences the pituitary gland. The pituitary gland is the master gland of the endocrine system, so it's in charge of all the other glands that secrete hormones. The pituitary gland causes the secretion of adenocorticotrophic hormone, which then causes the adrenal cortex to reduce corticosteroids. So you're basically the adrenal glands reducing these stress hormones that are allowing you to act. And that's how the HPA axis works. So if we're going to categorize stress disorders, we start with acute stress disorder, where the symptoms begin in 4 weeks of the event and last less than a month. So it's a short-term, intense, stressful response. Generally, this acute stress disorder will turn into post-traumatic stress disorder. And the reason is because, you're exposed to a chronic stressor, something so traumatic that it just overwhelms your ability to cope, and your body shuts down, and eventually you're so fractured by this stressful event that you have difficulty sleeping at night. You have these flashbacks, you keep thinking about it, you're constantly on edge, your body is hyper vigilant, you're aware of everything in your environment, you're not able to concentrate, and that begins a long period of symptoms that become classified as post-traumatic stress disorder. So acute stress disorder is less than 4 weeks, and generally, most of the time, it turns into post-traumatic stress disorder. Now, if you get immediate help, therapy, counseling, medication, pharmacological interventions, then you can try to offset this transition and you can kind of deal with the stressor. But in a lot of times, people don't have the resources to actually go out and seek help, or they're stuck somewhere where help's not available, like a war zone. And this acute stress disorder will just turn into post-traumatic stress disorder. And it's a very difficult disorder to treat. It's a long road back from post-traumatic stress disorder. It's possible, but it's a very challenging situation. It can be lifelong if you don't get the proper treatments. So here's the DSM-5 checklist. The person's exposed to a traumatic event, death, threatened death, severe injury, sexual violation, obviously rape, some kind of domestic dispute, domestic violence. And the person experiences after this event at least one of the following intrusive symptoms, including repeated uncontrolled distressing memories, repeated and upsetting trauma-linked dreams. So nightmares are generally very common in the post-traumatic stress disorder patient. Dissociative experiences such as flashbacks. So you feel like you've gone back to the same time in which the trauma occurred. And if if someone mentions anything that's vaguely related to the traumatic event, the person will become very upset, disturbed, and they have pronounced physical reaction. So that includes like elevated heart rate, that includes exaggerated startle response. So they're extremely on edge and they react to basically everything. And they'll be looking and scanning their environment for, symptoms or for some kind of significant meanings that may trigger this, reliving of the event. And that could be simply like a loud noise. So every little noise, the person scanning their environment, and anything that's, slightly louder, moderately loud, can then trigger going back to this flashback, going back to these memories, going back to having this extreme anxiety response. And the person is very hypervigilant. So they're always like that to the point that they can't sleep. Because in their mind, they keep reliving the problem. And they're afraid to sleep because of the nightmares. They don't want the nightmares of the event, reliving the traumatic event over and over again through their nightmares. So we call this nightmare disorder. That has to be treated as well. So a very serious disease or disorder that needs to be treated for a prolonged period of time. But the person will continually avoid trauma-like stimuli. So a lot of times they won't want to go out for the fear of being reminded of something linked to the trauma. They're going to be unable to remember key features of the event, or they experience constant negative emotions in general. They're just chronically in a bad mood. Depression sets in as well. As I mentioned before, there's changes in alertness, exaggerated startle response, sleep disturbances, and this lasts more than a month, and it creates a significant impairment to the point where, the person can't function in society. And the cases I've dealt with have involved veterans where they come back, they're discharged, probably for mental health reasons, discharged. And they come back and they can't get a job, they can't function, they can't sleep. They're trying to go to school, but they can't. They're struggling. It's a constant battle to get people reintegrated into society because you can't just flip the switch. You can't just go from I'm a soldier, I'm in Iraq or Afghanistan, and I'm dealing with bombs and guns and threats to my life constantly, and now you just have to kind of ignore that and go back to work, and it doesn't work that way. So the VA hospitals and the government in general need to do a better job transitioning troops from service to civilian life. Some people will transition okay, but there's a lot of people that don't transition very well, and those people need more support. Not just for PTSD, but just for getting their life back to what it was. You can't just build a soldier to go out killing machine, go out there and kill everybody and win whatever war we have or get whatever we need, and then all of a sudden flip the switch and come back to be like a normal parent and productive worker and member of society. It's tough. So that needs to, amongst the many other things we need, that has to also be something that we pay attention to and advocate for. So aside from the differences in onset and duration, the symptoms of acute stress disorder and PTSD are almost identical. They're reliving the traumatic event. They're avoiding any stimulus that reminds them of the event. They have reduced responsiveness in general. A lot of times they're either startled by everything or they kind of just float out into space. They're not really there. They're not presently with you. They're dissociating. So that's another response that people have is dissociation. And they have increased arousal, anxiety, and strange enough, guilt. They blame themselves a lot of times, with regard to the soldiers coming back from war. They're blaming themselves for abandoning their friends and their comrades, and their friends died and they didn't. And they think they deserve to die, and they have extreme guilt over abandoning. They want to go back, which is like the craziest thing. You would think that this impactful, extreme stressor of being at a war, you would want to be out of there. But they actually feel guilty for being out of that situation, and a lot of them want to go back and feel like they've let people down. And even in the case of domestic violence or rape, victims will often feel like, blaming themselves for what happened. Even though they're the victims, they tend to feel guilt that's unneeded because obviously it's not their fault. So that has to be worked on, processed as well. Is the guilt of removing yourself or the guilt of what happened and the aftermath of what happened. That has to be addressed. So what triggers acute and post-traumatic stress disorders? Well, they can occur at any age, affect all aspects of life. So these disorders ignore social class, they ignore political ideology, income, socioeconomic status, etc. At least 3.5% of people in the U.S. are affected each year by PTSD or acute stress disorder. Around 2/3 seek treatment because it's a really severe projection. It's a really severe disorder to live with. Greatly interferes in your life, so many people will actually seek treatment. Unlike, say, anxiety and depression, where people kind of will try to work through it and try to ignore it or deal with it in some other way. The ratio of women to men is 2-to-1, but this is also probably because women tend to seek more treatment than men. Not that women have more actual symptoms of PTSD than men. People with low incomes are twice as likely as people with higher incomes to experience these stress disorders, and obviously that's because having low income is a major stressor in itself. And it's harder to cope when you have low income and you don't have the availability of treatment or the ability to afford treatment in many cases. And some events, including combat, abuse, victimization, are more likely to cause distress than others. I've seen it a lot with combat, but you also see it with natural disasters. Maybe you'll start seeing it with this global pandemic as well. Hopefully this thing calms down, but this is a massive stressor. And, I can understand why people could develop some kind of disorder from it in the long run. Now, if we go back to the PTSD in the military population, many years ago, they called this shell shock or combat fatigue. That, the person in the middle of war or in combat just kind of gave up. They were just out of it. They couldn't function anymore. Post-Vietnam, clinicians discovered that soldiers also experience psychological distress after combat. So this has been going on since World War II, World War I, maybe even before that. I mean, we don't have records of psychological symptoms of say, like Civil War, but we have records from World War II that there was a lot of shell shock, and Vietnam was extremely traumatic to the many soldiers that were there fighting a war that basically could not be won, an impossible war. And there was a lot of pushback against it, obviously. As many as 29% of Vietnam combat veterans suffered acute post-traumatic stress disorder. An additional 22% had some stress symptoms. Many are still experiencing problems. Yeah, of course. I mean, it was, guerrilla tactics that were happening during the Vietnam War. You didn't know who your enemy was. It was a very difficult situation. It wasn't just a conventional war. It was an impossible war. And some will argue that it should never have happened, but many people that went over to fight in Vietnam came back and they were seriously disturbed. And we're seeing similar patterns with Afghanistan and Iraq. Obviously, you don't maybe hear it as much as you used to hear from Vietnam veterans all the time that had a lot of problems. They went public with their problems. They went public with their disapproval of the war in general. There was a lot of political pushback against the Vietnam War. You are seeing it with Afghanistan and Iraq soldiers. I know because I've actually met with several of these people, and there's definitely a problem there. I mean, just the experience of people being in a war zone. That's just something you can't simulate. That's something the body can't handle, the mind can't handle. The idea of being in a war zone. So, how this current crisis with the virus is going to affect us in the long run, we don't know. Because this is kind of like being in a war too. It's a war with an invisible enemy. Will we have people with PTSD following this? Probably. It's a natural disaster, and people are going to die. So we're trying to minimize it, but there's going to be a need for mental health after this whole epidemic passes. Mental health treatment, that is. This is the disasters I'm talking about in terms of earthquakes, floods, tornadoes, serious accidents, airplane crashes, global pandemics now. I mean, we haven't really had a global pandemic since, I guess you want to say 1918, which was the Spanish flu. I mean, there were a large number of cases in Spain, but it was a worldwide global illness. It wasn't just limited to Spain. And there are some estimates that that pandemic killed about 1/4 to 1/5 of the global population. Now, we won't see that with coronavirus, but you may see millions of people die across the world if we don't somehow get this thing under control. I mean, one of the models estimates the worst case scenario in the U.S. would be 2.2 million deaths if nothing is done. I'm talking about like sheltering in place or quarantine. So I think we're going to see a national quarantine this week. I think it's come to that. New York is out of control. Stay inside. You're gonna might see the National Guard on the streets soon. So they're gonna let anybody go out. I expect it to happen maybe this week. At the rate things are happening, people need to stay inside. Don't go out. I know I keep saying this, but don't go out. Stay inside. It's boring, but you can listen to my lectures. You can read about all different things and try to keep yourself busy and worry about all the other stuff later, the jobs. And it's an impossible situation for all of us. For some people are hit harder. I know a lot of the students are hit harder because of the job situation. This will turn around. It's just going to take some time, and in the meantime, we have to try to make do with what we have. Other things that trigger acute and post-traumatic stress disorder, victimization. So if you've been a victim of abuse, you may have lingering stress symptoms. So whether it's domestic violence or even bullying. Bullying is a big problem that can lead to extreme stress responses if not controlled. And this was a I would say a bigger problem, but has always been a big problem for many, many decades. The problem is no one did anything about it until Columbine. And after Columbine, schools have now started to crack down because of all the school shootings, crack down on bullying and try because bullying has a large long-term effect. It can be extremely traumatic for a young student to be bullied constantly. And back when I was growing up, no one said anything about bullying. It existed, and people would just be like, "Oh yeah, boys will be boys." Really? Boys will be boys? That's how you explain away bullying? But that's how it was explained away when I was growing up. But now, post-Columbine, it's been really cracked down. No tolerance policy. But bullying can be a means towards a stress disorder victimization as well, other than domestic abuse and rape and obviously things like that. Terrorism and torture. So we live in a world of terroristic threats, threats now. Since 9/11, it's been kind of amplified. The experience of torture, which unfortunately has been done in this country before. Something like waterboarding, which is absolutely ridiculous and the most inhumane treatment you could imagine. That was done following 9/11 to some suspected terrorists and actually to some innocent people as well. So the experience of torture, like a waterboarding, which makes you feel like you're drowning. So it gives you the feeling of drowning, constant drowning, like suffocating. And that's extremely traumatic. So global terrorism, 9/11, there was a lot of residual fear after 9/11 that the world was dangerous and that we were going to get attacked. And, could we defend ourselves? What happened with these planes? How could this happen in America? Well, we said that then. That was 2001, and I'm saying it now, almost 20 years later, with the virus. How could this happen in America? Unfortunately, America, they're very reactive. We're reactive as a society. We're not very proactive. And so although we've done a better job with terrorism, controlling it, we haven't done a better job in all other areas of our life, including preparing for, a global pandemic, which we knew was coming. As of several years ago, people knew for a decade that something like this was going to happen, but the U.S. government did nothing. I mean, there was an Office of Pandemics, but that got disabled in the last 2 years, and I don't know if that would have helped in some way, but yes, I mean, this is the problem with this country is we're very reactive and not proactive, and that leads us to these dilemmas. We had it with 9/11, and now we're having it with coronavirus. Unfortunately, both of these situations manifest around New York City. That's a very unfortunate experience, but that's where the global population center is. That's where the terrorism was, and that's where the virus is right now. So clearly, extraordinary trauma can cause a stress disorder. However, the event alone may not be the entire explanation, which means that some people have tremendous traumas in their lives and they never develop PTSD. And why is that the case? Well, it could be biological and genetic factors, changes in the brain that may lead you to be more prone to post-traumatic or acute stress disorders. So it could be genetic, it could be biological changes in the brain. We don't know exactly. We know that some people are more resilient. They're able to bounce back. They're able to deal with these negative events, with these stressors, and they're able to cope and bounce back more than others. And that could be both genetic and also be environmental, based on your previous life experiences. So as far as personality is concerned, certain personalities have a better coping style. Now, you're less likely to cope if you have pre-existing high anxiety. So if you have high anxiety before the trauma is just going to make things a lot worse, and you're probably not going to be able to cope. If you have a negative worldview before the trauma, that's also going to make you less likely to actively cope with the intense trauma you're dealing with, and more likely to develop PTSD. So you need to have a positive attitude. This is called resiliency or hardiness. How do you develop resiliency? I think some of it is personality based. Some of it is a inherent optimism in some people. Some people are very optimistic. They can handle a wide variety of problems that come their way on a regular basis. And they see the positives in life, and they feel that they're going to get through things, and these disasters will pass, and everything's going to be okay in the long run. So they have just a positive view on life. Other people have this negative worldview or this pessimism. They think that everything's going to go bad. That it's going to go bad quickly. and they're never going to recover, and the world will be different, and people will die, and, all these things, and everything's going to go to hell. It's going to go to hell fast. There's nothing we can do about it. If you have that kind of pessimistic, negative worldview, you don't have much resiliency. You don't have much ability to adapt to stressful situations, because the stressful situation just reinforces your belief about the world. So you say, well, I know things are going to go bad for me. Things always go bad for me. And now something happened, some traumatic event happened in my life or our lives. And look, this is exactly what I've been saying all along, that the world is going to hell. And, this is just confirms it. And so that kind of attitude is not going to help anything. It's going to make things worse. You can also have childhood experiences that are traumatic. So researchers have found that certain childhood experiences increase risk for later stress disorders. This includes impoverished childhood. So you grew up in a poor family, you didn't have the basics that you needed. You had psychological disorders in the family. So they tend to be genetic. They run from parent to child. Or you experienced assault or abuse at an early age. And the last one is kind of interesting, being younger than 10 years old when parents separated or divorced. So that is an extremely traumatic event for a young child, and that could put you at the risk for possibly developing acute or post-traumatic stress disorder later in life. Now, something that can offset that is social support. And social support sort of brings with it or sort of adds to the resiliency of someone against a major stressor. So if you have a good social support system, then you're less likely to develop PTSD or acute stress disorder following a traumatic event. That means you have a set of, people that are there to support you, whether they be family or friends, and you can get the assistance that you need. If you don't have anybody, you don't have any support system, it becomes much harder to fend off or to deal with this trauma, and you tend to develop these long-lasting conditions. There's also certain multicultural factors that lead to Hispanic Americans being more vulnerable to PTSD than other cultural groups. And this could be their cultural belief system, their belief about the world, um, their background in terms of traditions, their beliefs about social relationships and social support. There may be differences in how they cope with the trauma compared to African American population or to white non-Hispanic population. Obviously, the severity of the trauma plays a role. The more severe the trauma, the more direct exposure to it, the greater the likelihood of developing a stressor disorder like PTSD or acute stress disorder. Um, this is especially the case with mutilation or severe injury or witnessing injury or death of others. This is very traumatic. And amongst the people that were in combat that I had talked to going back several years, they described actually witnessing their friends blow up in a vehicle moving. They hit like one of these landmines that they placed in, I guess it was in Afghanistan, these improvised explosive devices, and their Jeep or whatever vehicle they were driving blew up, and people died, and they watched people die right in front of them. And this is something they couldn't get out of their head, right? This was something that kind of stuck with them, and they kept having this flashback and visualizing it. And they couldn't stop it. And so witnessing the death is a very profound, has a very profound impact on people dealing with trauma. Now, in terms of how to treat PTSD and acute stress disorder, about half of all cases of PTSD improve within 6 months. The remainder may persist for years. So it becomes a very difficult disorder to treat. And it requires a long-term intervention, so long-term therapy. And the treatment procedures involve ending the lingering stress reactions, gaining perspectives on painful experiences, and returning to constructive living. So that's a little harder to do than it sounds, right? I mean, this is a long process, and there are specific therapeutic treatments for this to help the person get through it. But it's going to take months, if not years, of treatment. So how do clinicians treat acute and post-traumatic stress disorder? Well, you can try drug therapy. Drug therapy is generally not that effective for these disorders. There's no drug that is FDA approved for post-traumatic stress disorder. You may try anxiety medications. Benzodiazepines are helpful for like the extreme stress responses. Benzodiazepines, which are the anti-anxiety drugs, are also helpful for nightmare disorder. There's certain blood pressure medications that are used to stop nightmares. They suppress REM sleep, so they suppress the nightmares. It's not really good to suppress REM sleep in the long run, but in a person with nightmare disorder, it's better to suppress it than to have the person have nightmares constantly. Then we want to also use behavioral exposure techniques. So we saw this with anxiety disorders, and now we're seeing it with PTSD and acute stress disorder. So what could be done here is reduce the specific symptoms to increase overall adjustment. You could use flooding and relaxation training. So basically you could relive the entire trauma, which is the flooding technique, in depth, right? Relive that traumatic experience in depth. And then you engage in a relaxation training. So a more modern approach to this flooding, what it's called to treat PTSD, is called prolonged exposure therapy. And so prolonged exposure therapy is the analogous of flooding. So you have the person recount every detail of the traumatic experience and to relive it over and over again and to like hang on to each part of it. And while you're doing that, you're teaching them relaxation exercises so they can cope with it. But by reliving the experience over and over again, you're trying to decrease the power of that memory. So eventually that memory will lose the potency that it has in drawing out the anxiety in you. And eventually you can remember it without feeling that physiological reaction. So that is analogous of flooding, but it's called prolonged exposure therapy. Another important therapy for PTSD and other traumas is called eye movement desensitization and reprocessing, which is known as EMDR. So this was a technique developed by Francine Shapiro in the 1980s, where she basically noticed that she was going for a walk outside and she was thinking about things that were bothering her. And she realized that her eyes were moving back and forth rapidly, scanning the environment. And while she was doing this, she claimed that she felt better about these negative experiences, these negative emotions. And so the idea behind EMDR, eye movement desensitization and reprocessing, is that the person is recalling the traumatic experience. So they're bringing it up in a therapeutic session, and the therapist is waving a light stick, like a little wand, back and forth in front of their face, so their eyes can travel back and forth. And while their eyes are traveling back and forth, some believe it sort of simulates REM sleep, and so they're able to process the traumatic experience that way. And over time, by doing this technique, reliving the trauma and then having the eye movements, this supposedly allows the person to decrease the intensity of these traumatic memories. So it works similar to prolonged exposure, except that there is this eye movement going on that hasn't been definitely documented exactly what it does, but people think it's similar to what happens during REM sleep, that you're able to process memories more during REM sleep. And by doing this through the EMDR session, you're able to process memories, and sort of those memories lose their potency, the ability to bring about negative affect. There's also insight therapy, where you try to create acceptance and lessen guilt. But the two most popular techniques here are going to be prolonged exposure therapy, which is analogous to flooding, and the EMDR therapy. Some patients have done this through virtual reality. So in virtual reality, PTSD clients use wraparound goggles and joysticks, and they navigate through a computer-generated military battle. So they're kind of reliving it in virtual reality. And some people say this is very effective. And virtual reality is going to, it's going to be out of control as far as the technique goes. I see this this is going to blow up soon because with the whole not going outside thing, you're going to have more remote therapeutic settings. And with the advent of these cheaper virtual reality systems, I think you could actually incorporate, distance therapy through the virtual reality system at home. So you may be seeing virtual reality in the home playing a bigger role in treatment, especially of PTSD, phobias, agoraphobia, things like that, even OCD maybe. You're going to start seeing more and more of this virtual reality therapy. So now we're going to move into a whole different ballgame. Not whole different, but something that's a little bit less defined and can be somewhat frustrating for me personally. And these are the dissociative disorders. And the dissociative disorders deal with identity, who we are, where we fit in our environment, our memories. We recall past experiences that help us deal with present situations, make decisions. But in these dissociative disorders, there is a disturbance, usually in memory. So people may not remember new information, they may not remember old information, they may not know who they are. They may feel sort of, detached from their bodies at times. So there's kind of this break away from identity. And that's what's common in these dissociative disorders, but they're very hard to identify and they're very hard to treat. They're called dissociative because the person's memory is kind of separated from the rest of who they are. So there are conditions where they completely don't remember events, so that memory is gone. In some cases of dissociative disorders, there are other cases where they don't remember who they are at all. They've completely lost track of all their memories, including self-identity. And then there are cases where the identity shatters into multiple pieces and they will switch off to these different facets. And that's specifically the dissociative identity disorder cases. So in these dissociative disorders, we have dissociative amnesia, we have dissociative fugue, we have dissociative identity disorder, which used to be known as multiple personality disorder, and we have depersonalization, derealization disorder, which is a really tiny, tiny piece of all the dissociative disorders. So dissociative amnesia is basically some kind of retrograde amnesia, which means memory of the past, that is due to something other than brain damage. So it's not like the person doesn't remember the prior 10 years of their life because they were in a massive car accident or they had a stroke or they were in a coma where there's actually physical damage to the brain. In the case of dissociative amnesia, the person's brain is perfectly normal. So if they go for an MRI, nothing shows up. And so there's no trauma, but the person has lost big chunks of their memory. They can't recall important life events, whether they're traumatic or stressful, that's gone. It's more than just simply forgetting. It's like losing a big chunk of your life. This causes tremendous distress and impairment. And these are not caused by drugs, substance abuse. It's not caused by general medical conditions. It's not a brain tumor. It's not a head injury, stroke, etc. It's of unknown origin. It's non-organic. It's due to some psychological trauma. That's dissociative amnesia. Dissociative fugue is different because not only do you lose a big chunk of memory or your entire memory in some cases, the person also loses their identity. Now, strangely enough, with dissociative fugue, not only do you lose your memory and identity, so you don't know who you are, you don't know anything about your life in general, but these people also, they travel, which is very bizarre. So sometimes they will travel across the entire country. So they'll go from the East Coast to the West Coast, and they end up on the West Coast, and they have no idea how they got there, and they have no idea who they are, and they end up walking around or stumbling. Maybe they end up in the hospital somewhere, where they have no identity and no idea who they are, where they belong, and they're kind of labeled as a John Doe or a Jane Doe. And it's just quite bizarre. Like, no one really can explain what's going on in this person's life. And why did they travel? And how did they travel? And when did the memory loss happen? And why don't they have any personal possessions on them? So many of the times, this person will travel, lose their entire memory, and then start a new life. Start a completely new life in a different part of the country. And generally, it's believed that this is due to an overwhelming trauma that causes the person to completely dissociate themselves, lose their identity, and then they work to regain their identity. In some cases, they will regain their identity. Just like in dissociative amnesia, in some cases, identity comes back, not identity, but memory comes back in dissociative amnesia very gradually. Fugues, on the other hand, tend to happen pretty quickly. So the person's living this new life, and then one day when they wake up and they remember exactly who they are and where they are and why they're there, and that's it. And they don't know how they got there. They don't know why they got there. There are cases of people that have started a whole completely different lives and married different people. And in the middle of their new marriage, under their new life, they remember their old life, and they remember they're supposed to be married to somebody else. And they don't know how they got there, and they don't know why they got there. And it's kind of like a medical mystery. No one seems to understand why this happens. They say it's due to a trauma, and there is a dissociation. But to me, that's kind of not a good enough explanation. So this dissociative fugue is kind of interesting. It's very, very rare. It's kind of interesting because we don't know much about it, and we don't know why this would happen, but it does happen. And so why do some people develop PTSD and other people develop dissociative fugue? I don't know. Genetics? That's the only thing I can really base anything on right now. I mean, it's different coping mechanisms. I don't know. It's not like a trauma creates it, because traumas create different disorders for different people. And in some people, they create no disorder. So this is just one of those things that it's hard to really explain. And it happens in a tiny, tiny fraction, much less than 1%, a tiny, tiny fraction of the population. And then we have one of my least favorite disorders, which is multiple personality disorder, or now known as dissociative identity disorder. So in dissociative identity disorder, there is one personality that gets splintered into anywhere between 2 and several hundred subpersonalities. And these subpersonalities have unique memories, unique behaviors, different emotions. They're like different people. And a lot of times the memories don't carry over, right? So one personality has a certain set of memories, and then when the person switches to a different person, a subpersonality, there's lack of memory for what happened with the other subpersonality. So there's a lot of gaps in memory with people with this disorder. It's a very, I would say, controversial disorder because the number of cases in the US was extremely, extremely low before the 1970s. And what happened in the 1970s, where there was this huge, sort of takeoff in multiple personality disorder cases, is the movie Sybil came out. I think it came out in 1972, or maybe that was the book first. The book came out first, and then the movie Sybil, where there was a depiction of multiple personalities happening. And once that movie Sybil came out, the number of cases in the U.S. skyrocketed. I mean, it jumped a lot. people were being diagnosed more and more with dissociative identity disorder. At the time, it was called multiple personality disorder. But what really happened, other than the fact that there was a very popular movie called Sybil that people watched and said, "Oh, that's me," or the therapist says, "Oh, that can happen. Maybe I've seen that in some of my patients." And that combination of the movie and the public becoming, aware of this disorder led to this takeoff in cases of multiple personality disorder. And that has kind of teetered down. It's kind of decreased over time. Starting in the 90s, it started decreasing. And it's still more prominent than it ever was. But how much of it is that it's a real disorder that people have, and how much of it is that it was developed or facilitated by the movie Sybil? And that's up to people to debate. People do not agree on, is it real? Is it generated from the movie? How much of it is real? I personally believe that there is a small, tiny percentage of people that actually have a genuine disorder, and then you have a lot of other people that may have been talked into it by their therapist. I think most therapists are ethical. However, there are some therapists that probably saw multiple personality disorder as a way of doing business. And I don't want to seem very cynical about it, but there are people like that. They don't want to lose patients, and this is, one way to keep your patient for a long time, because if you have multiple personality disorder, it's very difficult to treat it. It's a long treatment process. So these people are switching personalities. They have a major personality called the primary or the host, and that appears more often than others. But they may have 2 other personalities. They may have 10. They may have 20. They may have several hundred. There have been reported cases of people with hundreds of subpersonalities. I don't know how that works, but that's what they've been diagnosed with. Most cases of multiple personality disorder are first diagnosed in late adolescence or early adulthood. Symptoms generally begin in childhood after child abuse. So generally there's some abuse during childhood, which is the trigger for multiple personalities. And the multiple personalities is kind of like a coping mechanism. So the child learns that the different parts, the components, the different subpersonalities take over at different times in the child's life to help them cope, because they have been traumatized early in life. There's been some kind of abuse. So what we do know about this disorder, multiple personality or dissociative identity disorder, is that it starts in childhood generally, and that there is some kind of abuse early on that leads to this splintering of the personality into multiple pieces. Women receive the diagnosis 3 times as often as men, but once again, women go to get diagnosed. They go to therapy much more often than men. Usually it's twice as much, but in this case, it's a little bit higher. So is there another reason why they're being diagnosed more than men are, other than they're going for therapy more than men? And there might be. There might be a tendency to possibly interpret this behavior in some way by the therapist. Maybe the therapist is able to perceive personalities in women more than men. I don't know. Or it could just be that women are just going to get treated, and therefore they're getting diagnosed much more. That could be as simple as that. How do the subpersonalities interact? Well, there's generally 3 kinds of relationships. You have the mutually amnestic relationship, where the personalities don't know of each other. So they have no idea of who else is there. Then you have mutually cognizant, where each subpersonality is aware of all the rest of the subpersonalities. And then you have the most common pattern, which is the one-way amnestic relationship, where some subpersonalities are aware of others, but the awareness is not mutual. So that's the most common, is you have some subpersonalities aware of the other subpersonalities, but those other subpersonalities are not aware of some of the other personalities there. It's not mutual. Investigators used to believe that most cases were 2 to 3 subpersonalities. However, more current studies suggest that the average number of personalities is 15 for women, 8 for men. And as I had mentioned, there are cases of more than 100. So not only has the diagnosis increased over the years, but the number of subpersonalities has also increased over the years. 15 for women, 8 for men, and there are cases with over 200 subpersonalities, which is absolutely insane. I don't even know how you can have 200 subpersonalities. At least this is what has been claimed, and there have actually been lawsuits involved in these cases. Now, the subpersonalities differ from each other. They have different characteristics. It may be a different age, a different gender, a different sex, a different race. They may have different abilities. So some can speak a foreign language, other ones can't. Some can drive, other ones can't, etc. And there's even a physiological difference. So there may be a difference in blood pressure and heart rate amongst the different subpersonalities. And that is kind of interesting as far as I'm concerned, in that it does verify that there's something going on here. That why is there such a difference, physiological difference between the subpersonalities? So it's not that the person's making it up, but these subpersonalities are inherently different in some way. Now, is it overdiagnosed? Probably. Are there some people diagnosed with too many subpersonalities? Probably. But this all started with a movie, which is why I've given you the movie paper to write, because the general public is very much influenced by a movie. And you see this in the case of Sybil and the dramatic jump in diagnoses of multiple personality disorder, which is now called dissociative identity disorder. Traditionally, it was believed to be rare, but the number of people diagnosed has been increasing. It was really increasing from the 70s, the 80s, the 90s. Then it kind of started to level off a little bit. It's still much higher than it used to be before the 70s. Thousands of cases have been documented in the US and Canada alone. Now, besides the movie issue, could the movie have cued clinicians into the fact that this disorder exists and they should diagnose it? I mean, that's kind of scary if the clinicians are getting their how they diagnose clients from a movie. But is it possible? Is it possible that people just started saying, I have this, I know I have this, I seen the movie, now I know for sure it exists, and they go to their clinicians and they say, I have this, there has to be a name for this, and the clinician feels pressure to diagnose, to maintain the client? That's a possibility. Or is it truly that there was an increase, a legitimate increase over the years, and that this jump is just because people started paying more attention to it? It has nothing to do with the movie in general. The movie might have gotten someone's attention, and then people legitimately started looking for these symptoms. It's possible, but I mean that it's unlikely given the huge jump following the movie. Simple. So there are many clinicians and doctors and scientists that question how legitimate is dissociative identity disorder. And I'll show you some videos this week. I'll have you watch some videos this week that talk about the differences, and some people like it, some people are believing in this, and some people are completely against it. A variety of theories have been proposed to explain dissociative disorders. Now, newer viewpoints have talked about cognitive, behavioral, biological principles. These are really hard disorders to explain, and some of the explanations are really weak. So the behavioral explanations are very weak, so I'm not going to go through them. I'm going to start with the psychodynamic or the psychoanalytic explanation, because to me, this is one of the rare occasions that a psychoanalytic explanation actually makes a lot of sense and actually could be the case. The behavioral and the cognitive explanations are relatively weak, and they're not really worth going into detail here. So from the psychodynamic view, they believe that dissociative disorders are caused by repression, which is a defense mechanism, when you push uncomfortable or traumatic events into the unconscious. So people fight off anxiety by unconsciously preventing painful memories by pushing them out of awareness. That's repression. So dissociative amnesia and fugue are also episodes of massive repression. So there's a trauma, and you've repressed the trauma, you've pushed it out of consciousness, and that's why you have this huge memory gap. In the case of dissociative fugue, the trauma is so overwhelming, you've repressed all your memories and your identity. Now, that's kind of a little extreme to say that that could be massively repressed, but that's the psychodynamic view. And if you believe in psychoanalysis, that could make sense. I mean, that's a better explanation than, to be honest with you, a better explanation than the behavioral explanation, which I'm not talking about, which is state-dependent learning, and that's not really credible. No one really has a good explanation. So since no one really has a good explanation, the psychodynamic view comes out and says it could be this, and there's nobody to argue that it's not. There's not really a good explanation for what's going on here. So they believe that dissociative identity disorder is because of chronic repression due to early traumatic childhood events. So the person has been repressing their whole life, and that's what's splitting them off into different subpersonalities. They're repressing all these memories, and that's why the different subpersonalities don't remember what the other subpersonalities remember. Now, the problem with repression, the idea of repression, is that there is some evidence that when someone experiences a traumatic event, they remember it more. They have a more intense memory of it. It's called a flashbulb memory, right? So like, for example, memory of 9/11. People that were actually in the World Trade Center during 9/11, and I've talked to some people that were there, that escaped, that are alive today, screwed up but alive. They say that they remember this thing in great detail. So this is an extremely traumatic event, 9/11. You're escaping from the World Trade Center. How could you not repress that? Why would you remember this event in great detail, as some people claim? Wouldn't this be like the #1 target for repression? So if the psychodynamic or psychoanalytic view is correct, these memories should be repressed. You should have no memory of 9/11 if it was so traumatic to you. And yet people have vivid memories. And people with PTSD have flashbacks, like they're reliving the whole event over and over again. How does that make sense in terms of repression? So although I'm saying that the psychodynamic view has a better explanation than, say, the behavioral or cognitive viewpoints with regard to dissociative identity disorder or the dissociative disorders in general, it's still a very flawed explanation. It's something that you could believe in, but it's something that doesn't reconcile with the idea of flashbulb memory. You know, repression and flashbulb memory don't go together. They say different things. How do you remember something in great detail if you should have repressed it? That's the question for the psychoanalytic people, and they don't really have a good answer for this. So it's an explanation. It might be better because we really don't have much in the way of explanations for this, for these dissociative disorders. So this is something, but to me it's not 100% credible because of the repression issue. And this is what I was just saying in the previous slide. Why do only a small fraction of abused children develop this disorder if people should be repressing? So this is kind of this is based on some case histories. It's not based on a large sample. You know, psychoanalysis, when they do their research, it's usually case studies. So there's a lot of questions here that are not answered in terms of really supporting the psychoanalytic viewpoint or the psychodynamic viewpoint, the neo-Freudian. They have no explanation either. But neither does cognitive theory. Cognitive theorists have a pretty weak explanation. It's not even worth talking about. Behaviorists don't have a great explanation. Not worth talking about. So you could say how, it's a mystery. It's not known. So this is something. It's something you could believe in. I don't necessarily agree that it's the answer, but it's something. And it's better than what other people have come up with. The biopsychology, the psychiatry has no explanation for this. No one has any explanation for dissociative disorders. They're trauma-based disorders. That's all we know. We don't know how to treat them really well. I mean, there's some treatment plans, but there's no drugs for it. So if there's no drugs for it, then it can't be, a purely biological mechanism. There's no surgeries for it. So we're kind of grasping at straws in terms of what to do with this small population, but this very small percentage of people that have dissociative disorders have sometimes very severe illness, like losing your entire memory, your entire identity is pretty severe. People with dissociative amnesia and fugue often recover on their own. In the case of dissociative amnesia, the recovery is a little slower. In the case of fugue, it can be sudden. It could be like one day they know nothing, and the next day they remember everything. In some cases, there are some gaps that are still there, but these populations spontaneously recover. Is there really a treatment for it? Well, showing people pictures, showing people places they live, taking them to places they live can help jog their memories. Talking to people they know may help jog their memories. But there's no one protocol for treating these populations of people with dissociative amnesia and dissociative fugue. In contrast, people with DID have more profound issues, and the goal is to develop an integrated personality. So the goal of treating dissociative identity disorder patients is to merge the subpersonalities into one integrated personality if you can. This is difficult. This is not easy. People have been trying hypnosis. They've been trying, going back to childhood trauma, dealing with that, to deal with this. It's not easy to do. This is not a very successful treatment, but it does work with some people. Most people with dissociative identity disorder get some help with treatment, but it doesn't necessarily resolve all the subpersonalities. So they can live their whole life with different subpersonalities. Maybe you have some merging, but to completely merge all the subpersonalities into one integrated, coherent personality, that's a little bit rarer for treating dissociative identity disorder. So the psychodynamic therapists, as I mentioned, guide patients to go into their unconscious because they believe that identity and memory has been repressed. So I need to go back into the unconscious and bring about these repressed memories into consciousness. So that could be exploring childhood abuse, which is at the case of a lot of, the majority of cases of dissociative identity disorder. There is childhood abuse. So psychodynamic theorists want to go back to early childhood and explore that abuse. And by resolving that abuse situation, they can then recover these repressed memories. That makes sense. If the memories are indeed repressed, I have some qualms about saying that everything's repressed like this, but it does make sense to go back and resolve the childhood trauma. In hypnosis, which psychodynamic therapists don't generally do, but some do. Some of the field do. Not everybody does it, but some people do. Freud didn't like hypnosis, but the neo-Freudians are a little more accepting of it. Patients are hypnotized and guided to recall forgotten events. Once again, this is problematic. I believe in hypnosis for all kinds of things. I've done hypnosis myself. It works on pain. It works for anxiety. It works for different things. It might work for stop smoking for certain people. I think hypnosis is wonderful, but is it really good for recalling forgotten events? And the answer is no. Because in the case of the hypnotic session, there has been evidence that people will recall memories from their childhood that are false. So there's a lot of false memories recalled through hypnosis. So I'm very much against using hypnosis to recall childhood trauma because people develop erroneous memories and then make accusations against people that are not true. Like my uncle abused me when I was a child, or my father abused me when I was a child. That never happened. That was implanted through the hypnosis. That was suggested. I'm not saying that people doing hypnosis are doing anything necessarily wrong, but what I am saying is that it's not a perfect technique and there's a lot of false memories. If you're doing memory recovery with hypnosis, this is an area that you want to stay away from. There's even use of barbiturates. So barbiturates are sedatives. They were the first sleeping pills. They're inherently dangerous because if you combine them with alcohol, people can basically develop respiratory failure because their respiratory system gets suppressed so much because the barbiturates are very strong. People have overdosed on them and died of barbiturates treatment, especially in the 1960s because they were prescribed as the first sleeping pills. They're not prescribed today, so you can't get barbiturates no matter what. Even if you beg for them, you're not getting them. They're not a very safe drug. There's been some evidence that people can use injections of barbiturates to help people regain lost memories. And this has been known as truth serums. I don't know how much I really like this idea. That you gave them basically sodium pentothal or dosages of barbiturates, and you have them recall certain things. You ask them questions. How accurate are those recovered memories through these drugs? We don't know. But there is some kind of disability to free inhibitions. So it basically stops you from filtering. And so whatever's there gets access. So the psychoanalytic clinician will say these repressed memories kind of flood out because now there's nothing repressing them. You've disabled the mechanism that represses these traumatic memories. There's no study that's showing that these memories that are induced through drugs like this are truthful. There's a lot of haze there. There's some people that say, yes, these are events that happen. Other people say some of these events are true and some of them are false. So you have to be very careful with these kind of techniques if you're looking for the truth. People with DID, dissociative identity disorder, do not recover without treatment. So someone with multiple personalities or dissociative identity disorder needs extensive treatment to integrate the subpersonalities. It is a long process. It can be a lifelong process. It is not like a 6-week thing, 12-week thing. So it's also not going to recover on its own. So if you don't get treatment for DID, there's no spontaneous recovery like there is with fugue. Fugue, you can just be living a different life and then all of a sudden you remember everything. Dissociative amnesia could also resolve spontaneously. But DID does not resolve spontaneously. It's something that needs chronic treatment, mainly for years of your life. And once the diagnosis of DID has been made, therapists need to try to integrate the personalities together and educate the patients and help them recognize the problems that are inherent in this disorder. Therapists may also recommend group or family therapy, because if the different subpersonalities are emerging at different times, depending on who you're interacting with in your family, this is something that the family needs to be aware of too, to try to help the person merge the different subpersonalities. Right? Because the family may be enabling accidentally certain subpersonalities to sort of keep coming out. And so the family needs to be aware that there are subpersonalities, and these subpersonalities need to be shut down, ignored, modified in some way, interacted with in a different manner than what you're used to doing, with the hopes of trying to integrate these subpersonalities. Therapists will use psychodynamic therapy, hypnotherapy, drug treatments. As I mentioned before, it's very difficult to know exactly what works. We know what the goal is, to integrate the subpersonalities. How do you get there? Is it easier to get there through hypnotherapy? I don't know. Is it easier to get there through psychoanalysis? Possibly, but that's a long process too. And you have to believe in this idea of repression, and it's going to take you years upon years upon years. Can you do this with a cognitive behavioral session? Probably not. This is a very difficult disorder to treat. CBT is not very effective. DBT, dialectical behavioral therapy, is not very effective. Hypnotherapy is a mixed bag. You don't know what to believe and what not to believe, especially if you're trying to recover forgotten or repressed memories. Psychoanalysis also requires a little bit of a leap of faith to believe in the idea of repression. We do agree, though, with the psychoanalyst that there is a childhood trauma, and that's at the core of psychoanalysis. Dealing with childhood traumas that lead to later psychopathology. So in that regard, they're correct in saying it's childhood trauma. It's just what is the best way of sort of dealing with that childhood trauma? Is it, could you do prolonged exposure here? I don't know. I don't know if you can do that, because how do you repress, how do you get those lost memories. If you don't have the memory, there's no point in doing prolonged exposure. Can you get those memories out through hypnosis and then do prolonged exposure? Possibly, but is the hypnosis going to give you accurate memories? Maybe, maybe not. So we're at it's a real quandary as to how to proceed in the case of DID. People lean toward the psychoanalytic approach, but I think mainly because there's no other competing ideas that make sense or that are viable, really. I mean, drug therapy, it's not really viable. Giving someone barbiturates to help them recall past memories, there's, how ethical is that, and is it dangerous? Do you really want to give people barbiturates, especially given the dangers of barbiturates? I don't know. I mean, there's no real good way to solve this problem. So you want to try multiple approaches and see where you're making any progress if you're a clinician. The whole goal is to go back, explore the trauma, however you want to explore it, and then try to bring out the personalities and then reintegrate them. Easier said than done. It's not like the movies where, where you're watching Sybil, which was one of the originals, The Three Faces of Eve, which was a movie in the 1960s about multiple personalities. And then more recently, you had that movie Split, which is quite bizarre as far as how they describe the different personalities. And I actually seen that one. That was one of the movies actually on the list of all the movies I haven't watched. I decided to watch this one because students were constantly talking about Split and doing their papers on Split. And I watched it and I just kind of shook my head in disbelief. How bad it was, especially towards the end. It was just brutal. And this, you have the general public watch movies like this and actually somehow believe that they're telling something is true about how this is the way multiple personalities work. It's kind of scary. That's why the public is completely misinformed. I think you have to be careful what kind of movies you're making because people watch these movies and they believe them to be the truth. So, Split, it doesn't even get a split decision. It's a failing grade in my review. I'm no Gene Siskel. Well, thankfully, I'm no Gene Siskel because he's dead. I'm no Gene Siskel or Roger Ebert, but I can't recommend. I mean, some of you might like it just for the entertainment purposes, but as far as like giving an accurate depiction of the disorder, it fails pretty severely in giving an accurate picture of multiple personalities or dissociative identity disorder. And as I've been mentioning all along, the final idea behind treating the ID, the most important thing is integrating the personalities. How do you get there? As I mentioned before, do you get there through psychoanalysis? Do you get there through hypnosis? It doesn't matter how you get there, that's the goal. So that's the final goal, fusion, merging into one personality as much as possible, or cutting down on the number of personalities. Now, in the case of people with 300 subpersonalities, can you do that? Probably not. Do they really have 300? You're going to see videos of this, and you can make the decision yourself. But there have been some crazy amounts of subpersonalities that are diagnosed in patients that are just absolutely ridiculous. But is it real? Is it not real? I think it's real. I think it's a very tiny percentage of patients that generally have this disorder. I think it's overdiagnosed, probably because of the culture that we live in and the movies out there and the books, and the people are constantly talking about these things. But I do think it is real. I think it's a very tiny percentage. So if we go back to like the pre-1970 rates of diagnosis, I think we're around that rate, which is far less than 1%. And then it kind of took off. So it's become a cultural phenomenon, and I guess it's here to stay. Hopefully we find a better way to treat these people. So that's the end of the chapter on stress disorders and dissociative disorders. And I hope you enjoyed it, and I'll see you next time for our next chapters, which are going to be on depression, or somatization first and then depression. I think it's depression first. So I'll see you next week with a new lecture, and hope you enjoyed it. See you soon. Stay safe, be well, keep your family safe, stay in the house, stay in your apartment. I know it's painful, But we'll get through this. We need to do another couple of weeks of just staying home, and let's hope we all defeat this vicious beast together. If you have questions, email me. Come to office hours, which will be on Monday afternoon. I'll post a link, or you can just email me, set up whatever you need to set up. I'm available. So see you soon. Hope you enjoyed. Bye bye.